Yes, here we are with our third duo of experts, very optimistic, very joyful. I'm glad to know that in this profession you can be so full of joy. Jess, I'm intrigued to know that you prefer cats. We will be talking about dogs, and we will refrain from any references to movies.
Good
yes,
idea.
good.
That'll be best.
Let me introduce you to our audience. So we have Dr. Jessica Ward, a cardiologist and assistant dean at Iowa State University. You do research in addition to your clinical work with a particular interest in point-of-care ultrasound and pharmacology of the RAS. We've been talking about it and we'll talk more. And Dr. Jonathan Moschel, professor of systems pharmacology at University of Georgia, with a broad background in clinical and basic pharmacology and toxicology sciences, and focus on effects of various therapeutic drugs in complex biological systems. We're talking about one right now, including the heart and the kidneys. Very lucky to have you both. We have lots to talk about, specifically the treatments for MMVD at different stages. And at the end, we would love to cover some of the up-and-coming approaches for the future. So we are really very happy to have you both. Let's start with you, John. What kind of drugs do we have that impact the RAS?
Thanks, Vic. It's great to be here tonight. So when it comes to the treatment of congestive heart failure in dogs, really we have two main options for RAS modulators. We have the so-called ACE inhibitors that Darcy alluded to earlier tonight, which basically prevent the production of angiotensin II. And we do know that active excessive level of Ang2 will lead to detrimental effect, at least in human studies. And then we have the mineralocorticoid receptor antagonists, such as spironolactone, that also basically would be responsible for blocking the binding of spironolactone to its peripheral tissues, especially in kidneys. So overall, these two molecules will either prevent the production or the binding of these key modulators of the classical arm of the RAS, which centers around the Ang2 aldosterone axis. Now, next to this classical arm, as we've seen tonight, right, there is alternative pathways such as the ACE2 pathways that lead to the production of angiotensin 1,7 and 1,9 that we know have opposite effect, and by this I mean beneficial effect, especially regarding anti-fibrosis and vasodilation. So when you try to characterize the effect of a RAS blocker on the RAS, you really have to give the full picture of basically the effect on the classical and the alternative pathways altogether.
Thank you so much, John. Now I'm turning to Jess. Jess, Luca talked to us about the different stages of the disease. We heard from Michele when could be a good time to start the treatment. Talk to us, please, about how you treat advanced preclinical MMVD or congestive heart failure secondary to MMVD.
Absolutely. Thanks, Vic, and happy to give that overview. I should start by saying that we're going to focus in this discussion on medical treatment for myxomatous mitral valve disease. It is important to note that in humans, MMVD is essentially a surgical disease. Structurally, the best way to fix a leaky valve is to patch it back together. Surgeries and other interventions for MMVD are available now in dogs, but only at a very limited number of centers worldwide, and the expense is very high. Therefore, the majority of dogs who will be treated for MMVD will be treated with medication alone. If we think back to that staging system that Luca talked about, we can go through each stage and think about our treatments as a trajectory because the treatments build on each other as the disease progresses. Recalling back to stage A, those patients don't actually have the disease, so no treatment is indicated. In stage B1, where there's no to minimal remodeling, there are no treatments that have been shown to slow progression, so again, treatment is not indicated. Stage B2, as Luca alluded to, is the time when medication can become beneficial. And remember that we need some diagnostics and imaging in order to determine that that stage has occurred and we have significant cardiomegaly. And at that stage, the two medications that I recommend are pimobendan and an ACE inhibitor. We're going to go into a little bit later the rationale for that from clinical trials. When we then have the onset of congestive heart failure and clinical signs, which again, recall from Luca, that's not cough, that's when we have dyspnea and tachypnea, then we add on the diuretic, a loop diuretic, usually furosemide, as well as our additional RAS modulator, spironolactone. As we get into stage D, refractory congestive heart failure, that's when we can start thinking about either increasing the doses of some of the drugs that the pet is already on, including furosemide and pimobendan, but also adjunctive diuretics such as hydrochlorothiazide, adjunctive vasodilators, or if we have pulmonary hypertension, as Michaela and Giulio talked about, then sildenafil as treatment for pulmonary hypertension.
Very clear. Thank you so much, Jess. Now, if we go back to stage B2, which is when the treatment can be beneficial, what is the rationale for treating with pimobendan and ACE inhibitors, and what evidence do you have?
Excellent. Darcy gave a great overview of the pathophysiology of the disease and the reasons why some of these treatments might be beneficial based on the biology of the organism. What I'm going to talk about now is the evidence that we have from clinical trials, actually giving these drugs to dogs versus a placebo or no treatment and seeing what happened to them. Because biology is great, but it can be unpredictable. So seeing what an outcome is super important. For stage B2, when it comes to pimobendan, the study that demonstrated the benefit of pimobendan was called the EPIC study. And you can see here on this survival curve or time to event curve, we have two different groups of dogs, one group that received pimobendan and one group that received a placebo. Again, this is stage B2, so before heart failure. And what you can see is a longer time, about a 15-month delay of progression to congestive heart failure in the dogs that were given pimobendan over placebo. So this is a pretty well-established standard of care treatment for stage B2 in dogs. When it comes to the ACE inhibitor, things here are a little bit more controversial because we actually have two clinical trials that came to somewhat divergent conclusions. So we'll go through each of those. The first trial to talk about is the vet-proof trial. This trial took place in the United States and involved many different breeds of dog, all in stage B2. As you can see from this survival curve, the use of enalapril as opposed to a placebo resulted in an approximately 4-month delay until progression of congestive heart failure. However, kind of famously in our cardiology nerd circles, the p-value for statistical significance of the primary outcome measure in this study was just not quite enough to call it statistically significant. However, other secondary endpoints in this study were statistically significant. And in addition, a subset of these dogs, when followed to death, actually also showed a benefit of the treatment with enalapril over a placebo. So this study overall came to the conclusion that ACE inhibitors are beneficial in stage B2. However, the other trial, which is called the SVEP trial, this trial occurred in Scandinavia and involved just one breed of dog, Cavalier King Charles Spaniels. This again was comparing enalapril to placebo, but involved a combination of stage B1 and B2 dogs. As you can see from this survival curve, those two groups are completely overlapping. There was no difference in progression to heart failure for those two groups. So again, the evidence is not as clear-cut for this drug. If we think back to those ACVIM consensus guidelines, actually half of the panelists believe in the benefit of ACE inhibitors in this stage and half do not, which just goes to show when you get a group of experts together, they don't always agree.
Thank you so much, Jess. We spoke about B2 being treated by ACE inhibitors and pimobendan. John, some might question why not routinely recommend spironolactone in stage B2. What do you say to that?
Yeah, it's a great point because we do expect that some dogs with B2 heart failure will also have some level of aldosterone rebound, and so they could benefit from this class of medication. The short answer to this, I guess, is the study by Michele Borgardi's group, the DELAY study, that did not show any significant difference basically between this combination and the placebo in dogs with B2 heart failure. And there are multiple possible causes for this, one being that it's actually beneficial to leave the arm relatively untouched at the beginning of the disease, just to benefit from its hemodynamic effect. And then maybe the dose of benatril was actually on the lower end of the spectrum at 0.3 milligram per kilogram. And so we were not able to benefit from the full effect of this class of medications in that specific case.
Great. So that was stage B2. We move on to stage C, the disease has advanced, the dog is showing some symptoms, so difficulty breathing, congestion. Jess, there are some differences when we get to stage C. What are they, and what is the rationale of using ACE inhibitors and spironolactone in this stage?
Once we progress to stage C, of course, we're going to now start using a diuretic to remove the pulmonary edema. This is a life-saving emergency treatment. And these dogs will also remain on the pimobendan that they were on in stage B2. So we're going to focus on, as you mentioned, the evidence for the use of ACE inhibitors and spironolactone in this stage. When it comes to ACE inhibitors, we have 4 clinical trials that established a benefit of ACE inhibitors in dogs with congestive heart failure. And those showed various benefits, including long-term outcome, quality of life, as well as hemodynamic benefit. So these are, again, part of the ACVIM consensus guidelines. It is worth noting that there is one outlier study called the VALVE study, which did not find a benefit of adding an ACE inhibitor, ramipril, to furosemide and pimobendan. I think there are a number of reasons with the study design that make me not act on the results of that study. And those include, first of all, the dose of furosemide that was used in that study was pretty high. It was about 8 milligrams per kilogram per day on average, and that was for first-time congestive heart failure. That's quite a high dose, and actually, I believe we learned from Luca earlier, that's sort of where we're starting to define stage D congestive heart failure. And then the other reason is that the dose of ACE inhibitor that was used in that trial was pretty low, about 0.2 milligrams per kilogram per day, which is among the lowest of any of the trials. We know that furosemide activates the RAS even beyond activation associated with the heart disease. And so with that dose of furosemide and the relatively low dose of ACE inhibitor used, I'm not surprised that there was not an added benefit of the ACE inhibitor in that trial. So overall, to me, the preponderance of the evidence is still in favor of use of ACE inhibitors in stage C. Then when it comes to spironolactone, the trial we look to there is called the BEST trial. And in this trial, we compared benazepril alone to the combination of benazepril and spironolactone. And as you can see from this time to event survival curve, the dogs who also got spironolactone did better than those who got benazepril alone. So overall, this provides the rationale for the quadruple therapy that I mentioned earlier for treatment of congestive heart failure in MMVD, which is also in the ACVIM consensus guidelines: furosemide, pimobendan, ACE inhibitor, and spironolactone.
Super clear. Thank you so much, Jess, for walking us through all those studies and evidence we have. Now, John, we understand from what you both said the interest and utility of ACE inhibitors. How do you choose the dose?
Yeah, that's a very complex topic. So when you think about the drug and the dose, it's like a car and an engine, right? So you can have the best possible car. If the engine is not large enough, you won't go very far, right? So there is very value in trying to optimize the effect of drugs with the doses. Unfortunately, lots of studies in the past that have looked at ACE inhibitors, and the one that actually have been used for the dose determination in the past, have used ACE activity as a marker of RAS modulation. And we do know now that this specific surrogate is not a reflective measure of RAS activity. And so with Jess, we've been trying to kind of open the black box between the dose of an ACE inhibitor and its actual effect on the classical and alternative arm of the RAS together. And we started first with a retrospective analysis, which brought about 144 dogs with stage C congestive heart failure over 13 years. Now, what we have shown is that dogs that received a higher dose, above 0.5 mg per kilogram, did better overall than those receiving lower doses. So they lived longer, basically. We also saw that the use of this drug twice a day was protective overall versus the use of this same drug once a day. So obviously, it's a retrospective study, and there are lots of caveats with those kind of design, but at least it's a first step in the direction to show a possible dose dependency of ACE inhibitors. Then, in a second step, we conducted this time a prospective study in healthy dogs with a model of RAS activation, and we looked at different doses of benazepril on these angiotensins. What we have seen this time is that when you look at the effect of 0.5 mg per kg and per day of benazepril, you have on average a reduction of 50% approximately of angiotensin 2, which is the dark side of the RAS, and an activation of about the same extent, 50% of Ang1-7, which is the bright side of the RAS. So altogether, it seems that the use of these higher doses do provide a better modulation of both the classical and alternative arm of the RAS altogether. The next step was to build a mathematical simulator, like an online simulator to be used on an iPhone or just any kind of mobile device, and then simulate the effect of any possible dose of benazepril on those angiotensins. And again, we did confirm that overall, the higher the dose of benazepril, the better the modulation of the RAS, with the big caveat that these are based on healthy dog data, and we don't know how to translate a % reduction of angiotensin 2 to a clinical benefit. So we need to have more clinical data from actual dogs with congestive heart failure to really be able to determine what is the optimal dose of an ACE inhibitors in the context of the clinic.
There's work to do.
There's work to do, absolutely.
John, thank you. Jess, what about the combination of ACE inhibitors and spironolactone? Do we have the same dose or similar dose-dependent effect than for the ACE inhibitors alone?
As a follow-up to the benazepril project that John just mentioned, we actually did that study in a combination of benazepril and spironolactone together. And we saw basically the same dose-dependent effect of the benazepril when used in the combination, very nicely recapitulating those same results. The spironolactone, on the other hand, seems to be less dose-dependent when it comes to effects on the RAS, with a dose of 2 milligrams per kilogram once a day, essentially maximizing or optimizing the results on RAS biomarkers.
Well, thanks so much. I guess one more question I have on this is just how do you put all this research into practice and what it means for the practitioners that are watching and that have their patients coming in to the clinic?
Absolutely. As John said, there's still a lot of unanswered questions, but the way I interpret our current evidence is when it comes to ACE inhibitors, higher doses do more of what we expect the ACE inhibitor to do when it comes to the RAS. Our modeling would suggest that a dose that optimizes an ACE inhibitor's effect on RAS would be 0.5 milligrams per kilogram twice a day. So if I'm using these products independently, that's the dose that I choose for my ACE inhibitor, and that's also the dose that you'll find in the ACVIM consensus statement. I also think that our work with ACE inhibitor dose is very interesting when you then look back on some of the previous clinical trials that used ACE inhibitors, and perhaps some of the reason for the lack of clarity and not always having the same benefit had to do with the doses chosen in those trials, which were approximately 1/4 of the dose that our modeling would suggest is optimal.
And very quickly, because I see the time running, I see that the research that you have been focused on focuses on the biomarkers of the RAS. Are there other biomarkers that could be relevant, John?
Yeah, excellent point, Vic. So, besides the effect of Daxparo on the RAS, we do expect to see some level of activity in other biomarkers, including the one that modulate inflammation. And so this comes from a study in humans called the HOMAGE trial that did show some protective effect of spironolactone on markers of inflammations in people at risk of developing heart failure. So the next step for us is to do a study in vitro using canine stem cell to look at the effect of different doses of spironolactone on markers of inflammation.
And a quick look into the future. John, what's on the horizon if we talk about medical therapies for canine congestive heart failure?
For me, the most exciting drugs coming now would be the GLP-1 receptor agonist and the SGLT2 inhibitors. Those drugs have been showing fantastic results, first regarding cardiovascular and renal outcome in patients with type 2 diabetes in humans. But also, which was actually extremely interesting, is that those benefits extended beyond just modulation of glucose and in patients without diabetes.
And why is that the case?
Well, the whole concept really is that cardiac disease, renal disease, and metabolic disease all share some kind of a common denominator, which consists of a stage of subclinical chronic inflammation, oxidative stress, and metabolic dysfunction. And this is called the cardiorenal metabolic axis. So what we've been doing together with Jess and other investigators is to study the effect of a drug called dapagliflozin in a canine model of metabolic syndrome. And so we have looked at 2 different doses of these drugs. And what we have seen is that this drug was able to not only decrease the amount of glucose in the blood of this dog, but also increase the excretion in urine, which was to be expected. And thanks to those results, we were able to design then a clinical study, a pouch study in dogs, which Jess is going to mention in a few minutes.
Yes, because this one was on healthy dogs, right?
Correct.
And you did a study also on dogs with heart disease.
Exactly. So along with some collaborators from the University of Pennsylvania, we did just a small open label pilot trial in 10 dogs with stage B2 and stage C disease to basically see would the physiologic effect of dapagliflozin be the same in dogs with heart disease as in healthy dogs. And the results very nicely align with what we saw in healthy dogs. We were able to induce pretty profound glucosuria or excretion of glucose in the urine of these dogs, whether or not they had a background of loop diuretic on board. We're really excited about these results in hoping that this can help design a larger clinical trial to look at an outcome benefit of dapagliflozin on heart disease in dogs. It would be really exciting to have a drug that can induce additional diuresis, especially in patients with loop diuretic resistance, which is a topic that we did not talk much about today, but also the gliflozins cause diuresis without activating the RAS, which is a huge problem with our typical loop diuretic furosemide. So we're excited about the future.
Yeah, sounds very exciting and super helpful. Thank you so much to both of you for walking us through these treatment options and the different evidence we have for them. Don't run away just yet, because we want to look into a few quiz questions together. And let's scan that code one more final time. We have 2 questions. The first one being, what is the recommended treatment for stage C MMVD? 4 options, of which several answers are possible. So pymobendin, ACE inhibitor, diuretic, or spironolactone. And we give you a few moments to react. I see that about 90% of the people think that it's all 4.
You did a good job.
Let's see. I feel like, yes, you have done a very good job explaining, because, Jess, the correct answer is?
Yes, you might recall me saying quadruple therapy. All 4 of those drugs are correct.
Fantastic. So that one, well done. Well done. And the final question we have for you is, for which indications could the therapeutic family of gliflozin be licensed in dogs in the future? So we're talking about the future. Also several possible answers: diabetes mellitus, heart failure, osteoarthritis, or carcinoma.
It's a tricky one, actually.
Yeah, I see people voting. So, okay, let's see. 90% think heart failure is one of them.
That's a good start.
78% think diabetes mellitus is also a good one. And just a few clicks on the other 2. Are we getting close to the result?
Yes, and so, I mean, for now, it's diabetes and obviously heart failure. But with these drugs, you never know, because actually even in cancer, it seems that there are some benefits. So for now, A and B, but who knows in the next 5 years what they can discover, actually. So.
Okay, so lots of work to be done.
Yes.
Thank you, Jess. Thank you, John. I see the questions coming in.